everyone. My name is Saeed Hamid. I am a professor of medicine at the Aga Khan University in Karachi, Pakistan. It is also my privilege and honor to head the hepatology interest group of the WGO currently. What we thought we should do at this World Hepatitis Day, which is July 28th, of course, is to gather information from all our colleagues, all our HIG group members who are spread really truly globally, to get a global picture of what has been happening in terms of viral hepatitis elimination in their own countries and also in their own regions. In a way, this is a time for reflection in terms of the hepatitis virus elimination efforts, because the 2021 time period, which was the first global health sector strategy segment from 2016 to 2021, that was mandated by the WHO, has just ended. And WHO has, as you would know, come out with a report recently, which covers data up to 2019, but still gives us plenty of material to think about and to plan for the future, so that we are on target for elimination by 2030. So just to highlight a few important points from the WHO report. There is still, in 2019, there was still 1.1 million deaths, both from hepatitis C and hepatitis B. Of course, much larger from hepatitis B on a global scale. These numbers have come down since 2015, but certainly they are nowhere near to what our targets were. The number of new infections in 2019 were still 3 million for both hepatitis B and C. And again, this is somewhere where we need to reflect on what and how we will deal with this situation. If these new infections continue to gather, it will be very difficult to eliminate hepatitis B and C from the world, at least hepatitis C, if not hepatitis B. Now, the other, of course, the other part or event that has overtaken us globally has been, of course, the COVID pandemic. This has hit the whole world hard, as we know, and other services as a result have suffered, rightly so, because others, the main thrust was on dealing with this huge pandemic that is still ongoing. So, for example, according to the WHO report, there was 39% disruption in vaccination services across the globe, which means that 39% of our newborns in this time went either not fully vaccinated or not vaccinated at all. And this would include, of course, hepatitis B vaccination. Hepatitis B and C diagnosis and treatment. 25% countries globally report that there has been significant to major disruptions in terms of hepatitis B and C diagnosis and treatment. So there is a lot of catching up to do. However, look at the positive aspects. And the biggest positive aspect that comes out on this report is the fact that the hepatitis B prevalence in children less than 5 years of age has dropped down to less than 1%, 0.94% to be precise, which means that there is good activity in terms of newborn vaccination, where the rates of newborn vaccinations in various countries have gone up, and a number of countries have started to participate in the newborn vaccination programs. Of course, there is much more that needs to be done. So, in short, our work as hepatologists, as the hepatology interest group of WGO, is cut out for the next 9 years or so until 2030. And that is to even push harder for viral hepatitis elimination. And therefore, I very much like the slogan that the World Hepatitis Alliance has come up with and the WHO has adopted it, and that is hepatitis can't wait, which means that even though the COVID pandemic continues, we have to refocus on the elimination efforts of viral hepatitis globally. Otherwise, we will lag behind significantly. So with these few words, I hope that we will have a powerful global view from this effort from our various colleagues who will contribute, as I said, their data from within their own countries and the regions, and give us an idea of what is happening in what has happened in the COVID pandemic and what do they envisage will happen going forward. Thank you very much for your attention. And I hope that this World Hepatitis Day brings us rejuvenated efforts to eliminate hepatitis C and hepatitis B from this world. Thank you.
Hello, I am Gamal Esmat from Egypt, and it's my pleasure to introduce our plan for elimination of viral hepatitis. Egypt is a big country in North Africa with about 100 million population, and for HBV we were not facing any problems because the prevalence of HBV is less than 1%, and we started the vaccination for newly born since 1991, and we adapted the zero dose according to the WHO recommendation 2 years ago. But we were facing a big problem with HCV because Egypt was usually considered one of the biggest countries for prevalence of HCV, and we have about 15% HCV antibody positivity in the survey done in 1996. And we have the pleasure to start the activity of the National Committee for Control of Viral Hepatitis in 2006 to control this epidemic of HCV. And by the availability of the direct antiviral agents in Egypt in 2014, we were able to treat 1.5 million by the brand and generic drugs with success rate, sustained virological response, more than 95%. And at the same time, we know that we are not having any waiting list after that. We treated all HCV chronic patients that we know, but we know at least we have another 2 million having HCV, and if we didn't treat them, there will be availability for transmission of infection to the others, because everyone will transmit the infection at least to 4 persons during his life. So we decided to start macro elimination to look for those who are not discovered and undiagnosed. And this is why we started by the political will, by the presidential initiative to screen 60,000 million citizens adult, and we discovered 2.2 million with HCV antibody positivity. They were transferred to a specialized center to treat them. And we screened them at first on the 5,000 health rural units by the rapid test, the pre-qualified WHO rapid test. And those who are positive have been treated and investigated thoroughly before the treatment, all of this for free. And we treated all our patients for free. Thank you very much. Gamal Esmat, Professor of Hepatology and Gastroenterology, Cairo University, and WHO STAG member.
Hello, I'm Alice Lee. I work in Australia, but I've been working in the Pacific Islands for the last few years. I wanted to update people on the programs in the Pacific Islands where hepatitis B treatment programs have been up and running in a number of islands. and quite successfully. We have hepatitis B treatment available now in Kiribati, run by a really incredible team of workers on the ground, including Rosie, who is the task force chairperson, and as well as Fiji, where tenofovir is now on the essential drug list, Vanuatu, where it's also on the essential drug list. Tonga is also another country where antiviral therapy is available, as well as unique programs in Papua New Guinea, where we have a very unique partnership with a private company and a public exchange that is allowing for a small cohort of patients to receive antiviral therapy. We're working with other partners in addressing other needs in the Pacific Islands where hepatitis B remains highly prevalent and where access to care is really limited. We hope that we can expand it to some of the other islands where we can provide treatment for those who are most vulnerable.
Hello, I'd like to introduce myself. My name is Joost Drenth and I'm a gastroenterologist from the Radboud UNC in the Netherlands.
And my name is Marleen van Dijk. I'm a PhD candidate at the gastroenterology department in the same Radboud UNC, the Netherlands. And I'm working on a project called Sarin, where we retrieve lost to follow-up hepatitis C patients and relink them to care in the whole country of the Netherlands.
Yes, and hepatitis C is in particular a challenge in view of the low prevalence of the infection in our country. But we think that we are close to elimination, and we have a modeling study just to support that.
So what's next? We want to target the few remaining risk groups in the Netherlands. For example, we are currently implementing a targeted approach to HIV elimination in addiction care centers. However, the biggest remaining challenge right now is targeting the migrant population.
However, we are confident that we will meet the WHO standards by 2030.
So we invite you to join us to make the Netherlands hepatitis free.
Hello, my name is Dr. Zaigham Abbas, and I am president of Pakistan Society for the Study of Liver Diseases. Pakistan has world's second highest prevalence of hepatitis C. There is a pool of about 7.2 million hepatitis C viremic patients. The estimated pool of hepatitis B is 4.7 million. Out of these, 800,000 have hepatitis delta co-infection. Risk factors for hepatitis B and C in Pakistan include unsafe injections and the blood transfusion practices and use of unsterilized equipment by traditional healers and quacks. Pakistan is tackling high rates of hepatitis from many angles. The formulation of strict laws to regulate blood transfusion services and the introduction of auto-disabled syringes in the health sector are examples. The government is working on public-private partnership and the corporate sector for the prevention and control and treatment of viral hepatitis. The federal government has launched its National Hepatitis Strategic Framework that follows closely WHO Global Health Sector Strategy on viral hepatitis. However, there is a poor implementation of health-related policies and government-sponsored treatment programs are not very effective. Several other challenges hinder the elimination of hepatitis from Pakistan, including the lack of patient awareness about the causes and transmission of disease and lack of experienced healthcare professionals and affordability issues for investigation and drug treatment. The epidemic of COVID-19 has badly affected our efforts to eliminate hepatitis due to diversion of resources. In Pakistan, one person dies of hepatitis-related complications every 15 minutes. The death toll is much higher than COVID-19 in Pakistan. Hepatitis can't wait for COVID-19 pandemic to settle down. There is an urgent need to act now and facilitate the mass screening to find the missing million and boost up vaccination and treatment efforts to eliminate hepatitis as a public health sector threat by 2030. Thank you very much.
I'm Nancy Reau from Rush University Medical Center in Chicago, Illinois, United States. In recognition of World Hepatitis Day, I want to concentrate on the changing demographics of hepatitis C in the United States. It's been well recognized that those born between 1945 and 1965 have an increased risk of hepatitis C or increased prevalence. It's also now recognized that a younger cohort, those that are between the age of 25 and 35, also have an increased prevalence in parallel to the opioid epidemic. And although not yet accounted for, we suspect that this has increased during COVID due to the increase in opioid use and overdoses. Because of the changing demographic now being bimodal, this suggests that about 1 to 4% of pregnant women are actually at risk of having hepatitis C. And this impacted our screening guidelines. AASLD and CDC both early recommended universal screening in pregnancy for hepatitis C, but the American College of Obstetrics and Gynecologists, and then more recently, the Society for Maternal Fetal Medicine, then changed their guidelines. ACOG in May of 2021, and the Society for Maternal Fetal Medicine in June of 2021. So these are both very recent recommendations. Because of the increase in prevalence, it is now recommended that all women be screened for hepatitis C with each pregnancy. Remember, screening is with a hepatitis C antibody, and if it's positive, you do need to have a diagnostic study or a PCR, preferably through reflex, where it just automatically goes to that. If the mother is positive, rates of maternal to childhood transmission for Hep C are very low, about 4 to 10%, depending on HIV status. But it's still important to check the infant, either with a PCR test sometime in that first year or with a hepatitis C antibody at the age of 3. Having hepatitis C during your pregnancy does not change mode of delivery, so it is not recommended to have universal C-section, and breastfeeding is still encouraged. There is also a slightly higher risk of cholestasis of pregnancy in those that are hepatitis C positive. So you want to make sure if there's itching that you check those bile acids. I want to thank you for listening to this message, and with coordinated efforts, we really can achieve the WHO elimination targets. Thank you again.
Good morning, good afternoon, and good evening. I'm Mark Sonderup. I'm a hepatologist from the University of Cape Town and Groote Hospital in Cape Town, South Africa. I am fortunate enough to be part of the World Gastroenterology Organization's Hepatology Interest Group, and I also serve as a member of the Strategic Advisory Committee on Viral Hepatitis for the WHO, and I'm fortunate also to be on the board of the African Hepatitis Initiative. This Wednesday is World Hepatitis Day, and it is a time that we set aside every year, as indicated by the WHO, to pause and reflect on the burden of viral hepatitis globally. Now, Sub-Saharan Africa shares a significant burden of viral hepatitis. We, together with Southeast Asia and the Asian sub-region, share the burden globally predominantly for chronic hepatitis B virus infection. There are approximately 60 million Africans who are chronically infected with hepatitis B, and this contributes to the significant association and driver of hepatocellular carcinoma we still see in young individuals presenting with advanced disease to this very day. We have taken measures over the last 3 decades, with most countries introducing hepatitis B vaccine into their expanded programs of immunization. However, the one aspect that we need to work on and move swiftly towards is the introduction of birth dose vaccination. Now, if we look at the current lay of the land, only 12 countries across the sub-Saharan African region, in fact, have introduced birth dose vaccine into their immunization schedules. And this is something that is no longer tolerable. If we are going to achieve the 2030 goals set aside and as indicated by the WHO this year in terms of benchmarks to achieve the elimination of chronic hepatitis B virus infection. With respect to hepatitis C, we carry a significant burden as well, with approximately 10 million people chronically infected. The majority of both those infected with hepatitis B and hepatitis C, of course, don't know they're chronically infected, and more importantly, don't have access to the testing facilities available. So the motto and slogan for this year's World Hepatitis Day is Hepatitis Can't Wait. And that's what we say in Sub-Saharan Africa. We can no longer wait for birth dose vaccination. We can no longer wait for pregnant mothers to be screened for viral hepatitis. We can no longer wait for our governments and politicians to start taking hepatitis B and C seriously and advocating for the appropriate funding. We can no longer wait for testing and access to testing and treatment to be available to all. And so we endorse this year's slogan loudly and clearly: hepatitis can no longer wait.
Greetings from Kuala Lumpur, Malaysia. I'm Professor Chan Wah Kheong from the University of Malaya. It is my pleasure to share with you some developments in Malaysia in conjunction with World Hepatitis Day this year that carries the theme Hepatitis Can't Wait. My colleague, Professor Goh Kian Lee, is not able to join me for this video recording, but wishes to send his best regards. One of the more notable developments in Malaysia is the collaboration between the Ministry of Health Malaysia and Drug for Neglected Diseases Initiative, or DNDI. The efforts include a clinical trial on sofosbuvir and ravidasvir, a pan-genotypic DAA that was conducted in 6 centers in Malaysia and 4 centers in Thailand. The work has been published in Lancet Gastroenterology and Hepatology earlier this year and has led to recent successful registration of ravidasvir in Malaysia, providing an affordable treatment option to people with HCV infection. A strategic plan by the Ministry of Health Malaysia is also in place for decentralization of HCV screening and linkage to care and treatment, but there has been some setback from the current pandemic. Nevertheless, the efforts will continue with the aim to achieve the WHO elimination target. Like many parts of the world, non-alcoholic steatohepatitis is increasing. One of the more notable developments on this front here in Malaysia is the inclusion of metabolic dysfunction-associated fatty liver disease for the first time into the National Clinical Practice Guidelines for Management of Type 2 Diabetes. A simple and clear assessment and referral pathway has been provided so that MAFLD patients with less severe liver disease can continue seeing primary care or endocrinology where they are best managed, while those with more severe liver disease can be referred to gastroenterology or hepatology. A consensus statement by the Malaysian Society of Gastroenterology and Hepatology on this important development is currently in the works. Well, that is all from me, and I wish everyone a safe, healthy, and happy World Hepatitis Day. Thank you.
Hello, friends in liver disease worldwide. I'm Dirk van Leeuwen. I'm a clinical professor of medicine at Dartmouth College, and in that position, I closely interact with our friends in Rwanda for the Human Resources for Health program, where we try to contribute to medical education in this country. And on occasion of World Hepatitis Day, I want to pay for a moment attention to some aspects of hepatitis B. Hepatitis B remains worldwide, including Rwanda, a major problem. Not too long ago, one of our young pediatricians in his 30s died from extensive hepatocellular carcinoma related to hepatitis B infection, and that drew everybody's attention even in a more special way to this topic. Now, my observation is that many countries report that they implement the guidelines of the World Health Organization with respect to the vaccination of newborn infants. That brings, however, immediately an issue in pregnant women. There are still a significant number of pregnant women identified, and worse, not identified, that have chronic hepatitis B infection. And I think one of our opportunities is that we seek much more cooperation with midwives, with the people on the ground in the field, with obstetricians, gynecologists, and in training program to increase the awareness. And I'm saying this because one of my colleagues here who used to work as a midwife indicated that in medical records you rarely can find as to whether pregnant women are checked for hepatitis B. And so on occasion of Worldwide Hepatitis Day, I want to suggest let's intensify our cooperation with our colleagues in the field of obstetrics and gynecology at all levels to seek more aggressive implementation of checking for hepatitis B, where possible non-invasive assessment and possibly with fibroscan, something we can do here in Rwanda to assess also the severity of the disease and ideally check a viral load, and if that is a high viral load, see if we should pre-treat starting 3 to 4 months before the expected delivery, treat them with nucleoside analogs to prevent transmission around and after birth of hepatitis B. One case we identify and treat appropriately removes a source of ongoing infection in the community and a terrific opportunity. Speaking from Lake Champlain in Vermont, because these days our connections are still online, like many of you, but hopefully we will soon be in the ground in Rwanda as well. Wish you all the best. Thank you.
I am Shiv Sarin. I work in the Institute of Liver and Biliary Sciences as a hepatologist for the past 10 years. I'm very happy to communicate on behalf of my colleagues, friends, and policymakers in India on July 28th, World Hepatitis Day, on the National Action Plans on Viral Hepatitis Elimination. In 2018, ILBS, which is a WHO collaborative center on liver disease and viral hepatitis, through its persistent efforts was able to convince the government of India to launch a national viral hepatitis control program, which is probably the largest in the world, and it includes the diagnosis, the testing, including HPV DNA, HCV RNA, and therapy for hepatitis B and C throughout the country. This includes all patients with all categories. So hepatitis C treatment, a free treatment for patients. Hepatitis B diagnosis and testing and treatment is without any cost. I think through this, India has achieved major milestones. This has been continuing for almost 3 years now, and slowly it is increasing. Last year, we were able to generate enough awareness in the people, and this year again, on 28 July, the Parliament of India will be, through the speaker, hosting a program where the Minister of Health and Law, as well as the parliamentarians, would join, and they would be talking about hepatitis. In addition, there are efforts by several societies, including the Indian Association for Study of Liver, Gastroenterology societies, and other societies to increase awareness between specialists as well as patients. Patient networking groups are also working together to make hepatitis vaccination a priority despite the COVID pandemic. I would also like to add that there is a stronger urge on testing for hepatitis B and C, including NET testing in India for elimination of any further transmission. There is also a bottom-up approach in the community where the community health worker, whom we call as ASHA worker, is going, while they are testing for other diseases, including for COVID vaccination and others, they're talking about hepatitis B and C. I think there is a huge amount of effort which we still require. One of them is called empathy, empowering people against hepatitis. This program was launched in 2018, and all airports and civilian entry points for trams and metros have this display on empowering people, means to destigmatize and help them to get their status and respect and get their jobs properly done. This is empathy is a huge network which is by the people. And lastly, the policymakers, including the WHO CRO region, is holding initiatives in the country and in the CRO region for improving the lot of people for hepatitis B and C. But we have miles to go. Thank you all.
Hello, everyone. This is Professor Ibrahim Mostafa from Egypt, Director of Carrier Training Centers. My call today is, it is about my country, elimination of hepatitis C. The answer simply, it's eliminated. But we will go very quickly in the next 3 minutes what happened. We are at the high incidence of hepatitis C within Egypt, ranging from 15% in 2008 up to 10% to 2015. In 2018, it was this bacterial carcinoma was the second top cancers after breast cancer. These all indications, according to WHO definition, indication to eliminations of hepatitis C virus to get certificated by that. So in 1992, we start a national programs and aiming to create centers of hepatitis C all over Egypt, and at the same time to create a mobile team, to get a car team, to reach the outreach places, and also to increase the infection control and reduction the price of brand name drugs, and also to get a generic drugs to be more easy to be used. So by this means, we start. And then in 2018, which is a breakthrough, where we're starting a national, very extensive national programs. And this is very extensive national programs aiming to eliminate the hepatitis C. And this is, we done, examine 60 million persons, 12 years and over. And this is per day, we can examine up to 240,000 people by antibody and up to 36,000 by PCR per day. And this is, in my opinion, a magic. And in the same times, we discovered 2.2 million people with antibody. This is done in 7 months. And this is how done by 7,000 centers all over Egypt to do that. And the people working in that team, in that all that healthcare workers, it is 60,000 healthcare workers working in this project. Imagine this huge number. And at the same time, the cost of treatment is only $40 for 3 months, with sustained biological response is 98%. This is done through training, through everything. But the most problem, I think the most effective, that we get reduction of 90% of the incidence of hepatitis C virus, and we apply it now to the WHO to get a certificate that we eliminate virus C, and this is done in June, since 1 month, 2021, to get certificated that Cairo, Egypt, eliminate hepatitis C, and this is more details will come later in the news letters. Thank you very much for that. Thank you for listening to us.
This is Dr. Wasim Jafri from Karachi, Pakistan. I am Professor of Medicine at Dijk University and founding director of the World Gastroenterology Organization Training Center in Pakistan, and currently hold the same position as well. I have been previously General Secretary of Pakistan Society of Gastroenterology and founding president of Pakistan Society for the Study of Liver, and currently holds the title of patron of this society. The World Hepatitis Day is celebrated on the 28th of July every year. The last year's theme was Find the Missing Million. But unfortunately, and most unfortunately, due to the COVID pandemic, that theme from last year is still missing because the world efforts have targeted COVID because of the extreme morbidity and mortality associated with it. However, the ongoing efforts of hepatitis elimination still continues because the target date of 2030 would not wait longer than 9 years from today. So hence all efforts must be made by all the health authorities of countries like Pakistan, where hepatitis itself is an epidemic of extreme proportion. The hepatitis C prevalence figures are second to China only when it comes to viral hepatitis C positive cases needing treatment. I would urge the health authorities and the government of Pakistan and the global health authorities to continue with their efforts for hepatitis elimination, because complacency would certainly bring in more and more morbidity and mortality. Elimination itself does not guarantee that hepatitis cannot come back again with the same venom that exists currently. It only means that the mortality and morbidity that is currently happening from hepatitis would be greatly reduced by 2030, and vigilance must be continued even after that, so that hepatitis would not come back, in fact, in the same numbers as we have them today. So the World Hepatitis theme for this year is absolutely true, that we can't wait and our efforts must continue. And this is my request to everyone listening to various aspects of World Hepatitis Day programs, that please continue with your efforts so that we are at par with the rest of the world and Pakistan by 2030. Thank you very much.
Okay, I'm Douglas LaBrecque at the University of Iowa, Emeritus Professor of Internal Medicine and Director of the Liver Service for almost 40 years. The USA does not have universal healthcare system, and that may not be obvious to everyone around the world, where most countries, in fact, have a universal healthcare system, which greatly simplifies, although it doesn't necessarily pay for care. But it means everyone potentially has the same right to care. That's not true in the US, particularly for the poor, disadvantaged, and underinsured or uninsured patients. Now, President Obama created Medicaid expansion for this group, but it is administered not by the federal government, but by each state as they see fit, leading to vast differences in care from state to state. When Obama further enacted and expanded support for Medicaid to provide more care for those in need, states had to sign up to accept the Medicaid expansion, otherwise they would not receive it. Many states chose to refuse to do so, and that includes, unfortunately, my state of Iowa. They chose to hire a for-profit company to run their Medicaid program for them. They've changed the company every year since then because the companies have chosen not to continue because they were losing money and the state refused to pay them anymore. This has led to major problems with poor care for the patients, poor service for physicians, and poor service for hospitals, and overall less care for our hepatitis patients, among other things. But it applies to many of the other problems with Medicaid as well. To put it in perspective, in 2018, Iowa Medicaid earned a D, that's in Douglas, as in my name, grade, for its Medicaid access to hepatitis C treatment, according to the Center for Health Law and Policy Innovation at the Harvard Law School and the National Viral Hepatitis Roundtable. This was due to the erection of almost impossible requirements before they would approve treatment for hepatitis C. First, they required, initially by biopsy, a new biopsy, even if one already existed, that the patient had end-stage or F4 fibrosis, meaning they were already at late-stage disease, where treatment very likely might not even help and often was too late. Two, they required drug and alcohol sobriety testing over 3 months prior to initiating therapy before, again, they would approve it. These are the groups that were most in need of treatment in this group that was applying for Medicaid care. Additionally, to make it even more difficult, they required that only GI specialists could prescribe the therapy, even though any physician with a prescription pad could write for it. But they required that it be by a specialist. And since there were very few of those specialists in the state, and they would have to see the patient in person to do so, it would require patients to travel at times 4, 5, 6 hours to see a physician. And many of the patients in this category did not have such transportation. So that in itself was a major barrier. In January 1st, 2018, the state calculated 25,080 patients with hepatitis C. Now, given the fact that only 20% to 30% actually have ever been tested, much less know they have hepatitis C, modeling suggests that the true number in Iowa is well over 100,000 patients. This compares to a very accurate number for HIV of just over 1,000 cases. Many of these patients receive their care, if any, at one of the 13 federally qualified health centers scattered throughout the state or one of their 13 outreach clinics. So that's 26 different potential sources of care. And Iowa is in the midst of an opioid epidemic, as is most of the United States, especially IV, with the newer, more powerful fentanyl and other drugs. Numbers have increased tenfold over the past 10 years. And in tandem with that has been a tenfold increase of hepatitis C cases, particularly among the young under 35, who now have as many cases in Iowa per year as the baby boomers, the supposed higher risk group. Deaths have increased in tandem as well, particularly from IV overdose. And Iowa prisons are filled with approximately a 30% positive HCV carrier rate. Our prisons are fortunately testing for hepatitis C, but the vast majority have no money to treat it, so they merely let the patient know and tell them to find a doctor when they leave, which is where we try and pick them up. Our program is making a dent in the numbers of patients identified and treated, but it has a long ways to go, and there's much more that needs to be done. So we'll continue to fight. Things have improved in the state of Iowa. Now anyone can be treated regardless of their problem with fibrosis. However, they still require a GI diagnosis. They still require the 3-week or 3-month sobriety and IV drug abuse proof of not use of drugs. So that's a major issue that we continue to fight, and we'll be continuing to fight with our legislators and our governor to try and turn that around and make further progress. We must do this. This is something we can cure, and it's ridiculous in this day and age that we're not doing that. Thank you very much.
My name is Cihan Yurdaydin. I am the past president of WGO and currently work at the Department of Gastroenterology and Hepatology at Istanbul in Turkey, with a particular interest in viral hepatitis. The leadership of the World Gastroenterology Organization, or WGO, considers viral hepatitis as an important global health problem. It strongly supports the ambitious plan of eliminating viral hepatitis as a major public health threat by 2030, set forward by the World Health Organization, or WHO. The year 2015 was critical as WHO realized that global mortality figures from viral hepatitis had exceeded mortality figures from HIV, tuberculosis, and malaria. which led to their strategic decision to allocate more WHO resources for achievement of this goal. We, as WGO, globally representing gastroenterology and hepatology, with our more than 100 member societies and more than 50,000 members, support all efforts at combating viral hepatitis as part of our mission to increase and promote global public awareness of gastrointestinal and liver disorders. While we are truly a world organization, WGO has a unique role and responsibility, in particular towards the third world. A major source of viral hepatitis mortality comes from viral hepatitis B and C endemic countries in East and Central Asia and North and Sub-Saharan Africa, many of whom fell into the category of resource-limited areas. This explains our active participation in the World Hepatitis Day, and we truly think that viral hepatitis elimination, with all the achievements of translational science, is a timely defined, realistic goal for all countries, including resource-limited areas of our planet. Just look at the very good examples such as Egypt and Georgia. We are trying to do our part. Please do your part and raise awareness of this important, preventable, and treatable health problem. Thank you for actively participating and listening and watching these presentations.